Good evening, everybody. At the outset, I would like to thank the Starper group as well as Dr. Chandramohan, Dr. Harshavardhan Tanwar, and everyone for asking me to share my views on this important topic of initial puncture, that is percutaneous renal access in PCNL procedure. As everybody knows, this is the first and the most important step in PCNL. Going for a couple of minutes to its history, when I went to learn PCNL many years ago, I went to Dr. Pal to Nadiad, and I watched many surgeons. I read almost every possible book with chapters on PCNL in most of the books. When I saw different surgeons turning the C-arm in different directions, for example, Dr. Jaydeep Date used to turn C-arm towards the head end. Dr. Thakar from Gujarat used to turn the C-arm towards the foot end. And the Nadiad group used to turn C-arm towards the surgeon, whereas there are surgeons who turn the C-arm away from the surgeon. So I got confused and I started thinking, what is the logic behind these movements? And I came to some conclusions which I am going to share with you. Hello everybody. Today I am going to talk about the first and the most important part of PCNL, that is C-arm puncture technique, percutaneous renal access. When I attended the World Congress of Endourology at Mumbai, there was a lecture given by Steve Nakada, and there was a maximum attendance for this lecture. Also, when the Percon was first started by Dr. Pal, on the first day there were so many questions to him that next day he had to come and explain about the initial puncture. So especially for beginner, this is the most important aspect, and everybody was asking about the site of puncture and the depth perception, because if you don't hit the spot, it is demoralizing and you cannot proceed further. Now, I want to say there are 12 commandments for the initial puncture. So, we will go one by one. You must know all of them thoroughly before you put the needle over the back of the patient. Read all the available books with chapters on PCNL, particularly about percutaneous renal access. Now, let us go through these commandments. The first 5 are: the access is performed in a posterolateral position from lateral to medial and posterior to anterior. Second, the puncture should go through the renal parenchyma. Third, the direction should be towards the center of the calyx posterolaterally. Fourth, it should be towards the center of the renal pelvis. And fifth, the trajectory should not damage any of the major vessels. Now, further, sixth, we want to know 3 things. One is to mark the point of skin entry on the skin. We call it as SKD. It should be skin kidney distance. It should be as minimum as possible. In thin patients it will be less, whereas in obese patients it will be more. Now, secondly, to place the needle in the actual tract, that is the angle of entry. And third, to place the needle in the pelvic calyceal system, that is the depth. Now, 8 are over. Now coming to 9th. See, we all know that generally we have 2 types of initial punctures. One is bullseye and second is triangulation. Now, coming to triangulation, the direction of puncture is seen in 0 degree of the C-arm. It consists of superior, inferior and mediolateral directions, that is X and Y axis, whereas the depth or the Z axis is seen by turning the C-arm 30 degrees in any one of the 4 directions, and these directions are towards the surgeon or away from surgeon, towards the head end or cephalic side of the patient, or towards the foot end or caudal side of the patient. Now 10th, that is in bullseye technique, it is exactly opposite of triangulation technique. That is, the direction of the needle is seen in 30 degree, so you have to turn the C-arm 30 degree while inserting. Then the depth is seen in 0 degree, that is vertical position of the C-arm. Now the 11th commandment is, while changing one you don't change the other. That is, if you want to change the angle of puncture to adjust the depth, don't change the direction of the needle, and if you want to change the direction of puncture, don't change the angle of needle, that is depth perception. Now 12th and last but not the least is called as sign of parallax error and its elimination as described by Dr. Percy Chibber in his biplanar technique of C-arm puncture. In both 0 and 30 degree of the C-arm, the position of the tip of the needle should be in the same place and not in different places. This is done by changing the angle of puncture to adjust the depth after fixing the direction of puncture. Now, before I actually show you the video, this is another topic of debate, that is, how do I identify posterior calyx. The first is, when we do RGP in prone position, the calyces that fill immediately are usually anterior and are dark. The calyces that fill later and are lighter are posterior in prone position. Now secondly, as Dr. Kaushik Shah has pointed out, keep a referral radio opaque point on the skin posteriorly. The needle between this point and the calyx is posterior, and the needle beyond the calyx is anterior. After injecting the contrast by RGP, inject 5 cc of air into the pelvic calyceal system. Air being lighter goes to the posterior calyces, which looks white, whereas the contrast being heavy settles in the anterior calyces and looks dark. Now the fourth method of knowing posterior calyces is by turning the C-arm towards you and the posterior calyx moves away from you. In percutaneous renal access, there are generally 2 methods. One is bullseye technique, which was popularized by Arthur Smith from USA, and secondly triangulation technique, which follows the geometrical principles and guided by biplanar fluoroscopy, that is AP and oblique views. In AP we know the direction of the needle, whereas in the oblique view we know the depth of the needle. Now coming to bullseye, after injecting the contrast, we turn the C-arm towards the surgeon, and after identifying the posterior calyx, we angle the needle in such a way that the hub of the needle, the shaft and the calyx are all in the same axis that of the X-ray beams, so that on the monitor we see only a dot like a bull's eye. So this is how we start, and then we go inside for 2 to 3 centimeters and then turn the C-arm to 90 degree or 0 degree as we call, to know the depth. Advantages are it is relatively easy, and whereas the disadvantages are the puncture is too medial and too vertical, bleeding, perforation are more often. When we turn the C-arm in 30 degrees in whichever direction it may be, we look at the monitor of the C-arm, and the image we see on the monitor we analyze and come to the conclusion that whether the needle is superficial, that is posterior, or deep, which is anterior to the a calyx that we intend to puncture. When every surgeon was asked what is the logic and how do you analyze the image that you see on the monitor to determine whether your needle is posterior or anterior to the calyx. We did not get a satisfactory answer from any one of them. So keeping this in mind, we cannot by heart the position of the needle and its relevance to the depth perception. So in this video we are going to logically analyze the image that we see on the monitor and its analysis to a depth perception in the initial puncture of percutaneous renal axis. Hence I have given the title for this topic as the logical analysis of the image seen on the monitor at different 30-degree movements of the C-arm and its relevance in depth perception in percutaneous renal axis. To start with, we all know there are various methods to do initial puncture, that is ultrasound guided, C-arm guided, or even CT scan guided in difficult situations. However, here we are going to concentrate on C-arm guided puncture in a prone position, and I am going to take example of the right kidney. Let us talk little bit about the C-arm itself. The C-arm has got a tube through which the X-rays are generated. It has got an intensifier into which the X-rays are captured as they travel through the patient's body. This is captured in a camera in the intensifier. Now this travels through the C-arm into the CPU of the C-arm, where it is processed and from where the image is given to the monitor. Little bit about the positioning of all the equipments in OT. As Dr. Pal told, when the patient is on the OT table in a supine position, whichever side is the stone, that is on the right kidney or left kidney, on that side the C-arm monitor and all the endoscopic trolley, that is camera, light source, all should be on that side of the patient. So in this case, as we are presuming that the stone is on the right side, so I have taken it everything on the right side of the patient when the patient is supine. Also the sister with all the PCNL equipments and the pneumatic lithotripter or the laser should be behind the surgeon. The irrigation can be either behind or in front of the surgeon. When we first, before we start any procedure, we first try to see on the monitor whether we have positioned the C-arm properly or not. For this, we keep our hand in the direction of the X-ray and check on the monitor. We all know when the patient is positioned in the prone position, we make these markings, which are, this is the midline of the spinal column, this is the lateral border of erector spinae, 12th rib, iliac crest and posterior axillary line. So 95% of the time, most of the time your puncture will be somewhere in this region. To reiterate, we have made these markings. It is lateral is on the posterior axillary line, medial is towards the spine, up is towards the head end, that is towards the 12th rib, and down is towards the foot end of the patient. And these same markings are made on the monitor of the C-arm. So if you see on the monitor, I have made markings L lateral, M medial, 12 o'clock that is up cephalic, and 6 o'clock is down, which is caudal. I put my hand in the direction, in the pathway of the C-arm to check that the monitor, the image we are seeing on the monitor corresponds with the markings that we have made. That is, if I move it on the lateral side, it should move on the lateral side, that is L, and if I move it on the medial side, it should move on the medial side. And my tip of the finger is cephalic, you can see the 12th rib, so if I go up, it should go up, and my wrist is in the caudal direction, which is at 6 o'clock, and this is what I see on the monitor to make it correspondingly same. Of course, some urologists turn the image on the monitor in such a way that the spine lies in a transverse plane on the monitor during the initial puncture. However, we are not going to consider that at present. Now, as you can see, on the intensifier of the C-arm, we have also done marking the upper portion as cephalic, or what we call up, then the caudal portion or to the foot end as down, and lateral to the patient in prone position as lateral, and medial is towards the spine as medial. We have made these markings for our future reference. Now please remember that we have not changed the what software we have got in the CPU and how we are feeding the image to it, nor we are changing any position on the monitor. Thirdly, we are not changing the position of the patient. So these three things are constant. The only thing we are going to change is the movement of the C-arm. However, because the CPU of the C-arm recognizes lateral as lateral, medial as medial, cephalic as cephalic, and caudal as caudal, these will get reflected on the monitor irrespective of the way we move the C-arm. As you can see, the C-arm is positioned at 0 degree. We are presuming that what you are seeing, the radio opaque, which I have kept as a ECG lead on the anterior abdominal wall, and I have kept my needle on the posterior abdominal wall. Now in 0 degree, both appear to be in the same place. Now I am going to turn the C-arm towards me, and you can see on the monitor that the needle has gone medially in relation to the radio opaque shadow. When we analyze the movement of the C-arm, we realize that what we have written lateral has come anterior in relation to the position of the patient. As the patient is prone, this side is back and this side is front. So compared to what it was before, the lateral has now come towards the anterior part of the body, while the medial side, which was initially medial on the intensifier, has come to the posterior part of the body. However, the CPU of the C-arm recognizes this as a lateral only and this as medial only. Although the lateral has moved anteriorly and the medial has moved posteriorly. The CPU of the C-arm recognizes this, the lateral side, still as lateral only, although it has come anterior, and the medial side, although it has come posterior, it recognizes on the monitor as medial only. Now I am moving the C-arm away from me, so away from the surgeon. Now I am turning the C-arm 30 degree away from me, and you can see you can see that my needle has come lateral to the shadow. That means it is LP, that is lateral is posterior, and if you see below, the medial has gone anterior and the lateral has come posterior. That is why you are seeing the needle lateral to the desired calyx. Now again in 0 degree of C-arm, I have kept the needle on the radio-opaque shadow. Now I am going to turn the C-arm towards the head end of the patient. It is being turned, full stop. Just stay. Now what we are seeing on the monitor, the needle is below and the shadow is above. Now this is because the up or the cephalic has moved anterior and the caudal has moved posterior. So as the caudal is posterior, as my needle is posterior to the shadow, my needle is being seen as a caudal to this image. You can see the cephalic has become anterior and the caudal has become posterior, while the lateral and medial remain constant. Now I am going to turn the C-arm towards the foot end of the patient. Turn the C-arm, and now you see what, stop. Now see what happened. The needle has gone up when compared to the shadow here. This is because the caudal, what we have marked, has become anterior and the cephalic, what we have marked, has become posterior, and as my needle is posterior to the shadow, you are seeing it as cephalic or above the shadow. You can see in this picture what initially was caudal in 0 degree, when the C-arm is turned towards the foot end, the caudal has become anterior and the cephalic has become posterior, while the lateral and medial remain same. Now I want to show you how in a simple way you can practice this initial puncture. All that you need is thermocol of 2 to 3 inches size, 2 in number, and a puncture needle and a C-arm, and all this to be kept on a radiolucent tabletop. And in between the two thermocols, you can keep a radio opaque object, something like a coin or a ECG chest lead, and keep this entire thing under the C-arm with minimum X-ray projection, and keep your needle and start practicing as I have described before. Now I am going to demonstrate on a practicing model where I have taken 2 thermocol and I have kept in between a ECG electrode, and I am going to demonstrate how we can practice puncture. Now, presuming that this ECG electrode is the aim of our puncture that we intend to puncture, I am seeing in 0 degree of the CRM, and I am going to get my direction right. I am going to come back about 2 to 3 centimeters behind, and I am going to angulate it by about 45 degrees, and I am going to go inside. I am not going to change the direction of my needle, and now I don't know whether I have hit the right area or not. Now, to know, I am going to turn it 30 degrees. Now, this is 30 degrees towards the head end of the patient. As you can see on the monitor, the needle is still on the ECG probe only. So, hence this is called as sign of parallax. If you see the needle and the desired target in the same spot in both 0 and 30 degree, that means you have hit the right spot. This is, again I reiterate, this is called as sign of parallax. Now I am going to demonstrate what happens when we turn the needle, when we turn the CRM towards me. I have come back and I have taken an angle and I have started puncturing without changing the direction. Now I don't know whether I have hit the, it looks like as though I am hitting the right spot, but now I want to change it and see what happens. Now I am trying to do a puncture. Now I don't know whether I have hit the right spot or not. Now I am going to take a 30 degree towards me. Bas. So as you can see, the needle is lateral to the intended target. So I am going to withdraw it. So lateral is anterior. So I am going to go again. I am going to make it 0 degree, and I am going to change the angle little bit so that I want to go more posterior. See, I have gone again. I am going to make it 30. See, now I have actually I am actually in the same spot. So I am hitting the target. Now in 0 degree I am on the spot. 30 lage माझ्याकडे घे. See, again I am on the spot. So that means I have hit the target. Now let us try. Shoot. Dr. Pal used to say the intended target that you want to hit on the right side, when you are doing on the right kidney, it should be at 11 o'clock in the somewhere here on the screen, whereas if you are doing on the left side, it should be somewhere at 1 o'clock position. So now because this is right side, I have kept it nearly around 11 o'clock position. Now I am going to come back and again start puncturing. As I told you, I am not going to change the direction. I am only changing the depth, that angle of puncture. And now I am going to turn it towards the foot end of the patient. Bas. So as you can see clearly, on the monitor the needle is below. So that means I have gone too deep. So I have to withdraw. And go little bit more superficial, where I am going to say I have hit the target. That shadow is moving now. Again bring it to 0 and confirm your direction. So now both the direction and depth in both the angles, the needle is in the same place. This is again sign of parallax. Now the same thing, now I am going to withdraw. Again I am going to try and go. Now I don't know where I am. Now I am going to turn it towards the head end of the patient. Bas. Now I am below. Now as I told you, if we are below, we have to go down, we have to withdraw and go down to hit the target. See, now I have hit. I am already moving the needle. Full stop. Again bring it straight. Now again I am going to withdraw, and lastly I am going to show turning it away from me. Now this is the needle. I am going to come back and I am going to try keeping that as the target. Now I don't know where I am. Now turn it away from me. So now I have gone medially. If it is medial, when I am turned away from me, that means I have gone too deep. LPMA. So M is a anterior. So I have to withdraw and go slightly more posterior. See, now I am hitting the target. I changed the angle and got it little bit more posterior, and again I went inside. Now come to 0, and there we are. The moral of the story is, in a triangulation technique, we start from with 0 degree to know the direction, whereas to know the depth we change the CRM to 30 degree. It doesn't matter which way you turn the CRM, either towards you or away from you or towards the head end of the patient or towards the foot end of the patient. As long as you know the image that you see on the monitor, how to analyze it, and you come to the conclusion whether your needle is posterior or anterior to the calyx, that is whether you have gone too deep or you are superficial. You can correct it by withdrawing the needle and readjusting the angle and going into the calyx. So this is the in a nutshell the philosophy behind analyzing the image that you see on the monitor at various 30 degrees of CM. I hope this concept of logically analyzing the image that you see on the CM at different angles, 30 degree angles of CM, has been of help to you. Thank you for watching.